Apicals remove air. Basalars are at the bottom of the lungs, so they will remove what? Blood, because blood is subject to gravity. So apicals remove air, basalars remove blood. A for A, B for B. What do I mean by that? Apical starts with A, and that removes air, which starts with A, and basilar starts with
B,
and it should remove
blood.
So if they say your apical chest tube is draining 300 milliliters per hour, your apical is draining 300 per hour, what do you think? Good or bad? Bad. Your basilar is draining 200 mils per hour.
Yeah.
Fine. It needs to come out. You know? Your apical tube is not bubbling. Your apical tube is bubbling. Your basilar tube is not bubbling. Fine. Your basilar tube is bubbling. Why? You know what I'm saying? So do you see where location depends? So what will they put in for a hemo? What will they put in for a pneumo? And what will they put in for a pneumohemo? One of each. Which brings up the next three questions. Examples. How many chest tubes and where would you place them for unilateral pneumohemothorax? Unilateral pneumohemo. Two. You'd use a apical for the pneumo and a basilar for the hemo. B. How many chest tubes and where for a bilateral pneumo? Again, how many? Two. But what would they both be? Apicals. You'd use an apical on the right and an apical on the left. Then letter C. How many chest tubes and where would you place them for post-op chest surgery? Here again, two. An apical and a basilar on the side of the surgery. Because you are to assume that chest surgery or trauma is unilateral unless otherwise specified. So if they just said he had chest trauma, would you assume it's unilateral or bilateral? Unilateral. Chest surgery, unilateral or bilateral? Unilateral. You always assume unilaterality. Never assume that it's bilateral. So the only time you're taking care of bilateral is when they say bilateral. Alrighty? Oh, there's a trick question though about chest tubes. How many chest tubes would you need and where would you place them for a post-op right pneumonectomy? None. Why? Pneumonectomy means removal of the what? Whole lung. There's no lung, there's no pleural space, there's nothing. So if there's no pleural space, why do you want to reestablish pressure in something that does not exist? Correct? So you do not use chest tubes for pneumonectomies. You use them for lobectomies, wedge resections, those kinds of things. All right, turn the page. Let's talk about troubleshooting. Do you guys remember seeing closed chest drainage devices like a Pleurovac, Thoravac, Pneumovac, Emerson? And they're those plastic containers that the tube is connected to. Well, what do you do if you knock that over? I mean, you didn't break it, you just knocked it over. What do? Set it back up and have them take some deep breaths. Is it a medical emergency? Does the physician need call? Does the RN need notified? Do you need to do anything other than have them take a couple deep breaths? No. It is no big deal. Do you understand that? So do not get all uptight when you knock over that device. But number two, what do you do if the water seal breaks? The actual device, that device breaks. Now, is that the same thing as we were just talking about, or is this something totally different? Totally different, because now positive pressure can get in the pleural space. So what do? Let's say you break it. What do? Clamp it. That's the first thing you do is clamp it. Why? so nothing gets in. Then what do you do next? Well, there's a couple of steps they're going to put in between there. Clamp it.
Put it in zero water.
There's a step before that. That's the third step. Clamp it. It's too obvious. Cut it away from the broken device. Take your scissors and cut that tube away from that broken device because it's no good anymore, right? So cut it all away. Then, what do you do to the end of that tube then that's been cut away? You said it in the back here.
Zero water.
Stick that end of that tube under sterile water, okay? Now, what are you going to do next? Unclamp it. Why unclamp it? Because now you've reestablished the water seal. Do you understand? It doesn't need clamped as long as it's under water. And it's better to be underwater than to be clamped. Why is it better to be underwater, the end of the tube underwater, than for the tube to be clamped? Why is it better?
Sterile.
No, not sterile necessarily. Air can't go in, but stuff can come out. If it's clamped, what's the problem? Nothing can go in or out. And you want stuff to come out. You don't want stuff to go in. So clamping is only a stop-gap measure. It doesn't solve the problem. What solves the problem? Sticking the tube underwater. So what is the order? If they gave you a click and drag, when the water seal breaks, what would be the first thing you'd click and drag? Clamp, then what? Cut, then submerge, then unclamp. It's alphabetical. Clamp, cut, submerge, unclamp. Clamp, cut, submerge, unclamp. That is your order. So if they said to you, what is the first thing you're going to do when the water seal breaks? The first thing, what will you pick? Submerge the end of the tube underwater or clamp the tube? Clamp. Because when they say first, they're asking about what? Order. Right? But what if they say this? They ask you the exact same question with the exact same answers, and they change one word in the question. The word they change is from first to best. And they say, what is the best thing to do when the water seal breaks? What is now the answer? Submerge it under sterile water, the tube under, the end of the tube underwater. Why is it the best? Because it actually solves the problem by reestablishing the water seal. The clamping was only what? A temporary fix. It's not the best, it's the first, but it's not the best. So do you understand that a best question is different than a first question? Very different. A first question is asking you all about order. A best question is asking you what's the one thing you would do if you could only do one of these. So if you could only do one, clamp it and nothing else, or put it under the end of the tube underwater and nothing else, which one would you do if you could only do one? Submerge. So it's what? Best. Because what's the best answer? The one that you would do if you could only do one. What's the first one? The one you do first. And that may be the same and it may be different. But a lot of people screw up questions because they're answering firsts instead of bests or bests instead of first. And they're not paying attention to what the question is asking. For example, and this is really important to get because people have trouble with this. You notice a person has ventricular fibrillation on the monitor. VFib, good or bad? Bad. No cardiac output. You run to the room, they're non-responsive, and they don't have a pulse. What's the first thing you're going to do? A, place a backboard. B, begin chest compressions. Now, first is about what? Order. So, you're between those two, right? So if you pick place backboard, what are you saying? I'm going to place the backboard first, then I'm going to start chest compressions. If you pick chest compressions, what are you saying? I'm going to start chest compressions, then I'm going to place the backboard. Well, what would be better to do first? place the backboard. And remember, it's a perfect world, so where's the backboard? Right there. Boom, it's there. Don't say, well, it could take 10 minutes for somebody else to bring the code. No, it's a perfect world, it's there. Okay? So, what's the first thing you do? Place the backboard or begin chest compressions? Place the backboard. But what if I say this? Person has VFib, they're unresponsive, no pulse. What's the best thing to do? Place the backboard or begin chest compressions? Well, if you do one of those, you don't get to do the other one. You understand? In a best question, how many things do you get to do? One. And if you do one, you don't get to do the other one. So if you pick backboard as the best, what are you saying you're going to do? I'm going to roll them over, put them on the backboard, and go, oh, okay, now. They're still not getting the pulse. Hopefully somebody will come along before 8 minutes, right? But if you pick chest compressions, what are you saying? I'll do chest compressions while they're on the floor. They get no backboard.
Right.
Well, would you rather do chest compressions without a backboard or a backboard without chest compressions? Which one's best? The chest compressions. Which one's first? The backboard. Are you getting this? First versus best? We're going to talk a lot about this in the next 3 days, so you get good at this. Most people don't even catch the difference. They just right over. No, not you guys, but a lot of you. Number 2, what do you do if the chest tube gets pulled out? Have you ever seen that? I've done it. Yeah, I did. I worked at Southwest 9 and when St. East was open in Dayton, Ohio. I had worked in the intensive care unit from the Open Hearts, and they had these chest tubes and everything. Well, this guy's huge. Well, he's like 10 times my size. Well, that's not hard to beat, but he was really big. And I knew that I had to get him in bed, and I had one chance. Otherwise, we're both going down. And I had to do it all in one motion. So I got there like this, wide stance. The bed's here, he's here. I got the belt, and I think, okay, now. And I thought, oh, your stance isn't wide enough, so I went. And when I went like that, I stepped on his chest tube.
Oh, no.
And I did not know it. And I went, okay, 1, 2, 3. And I lifted him up, and out came because I'm standing on it, got pulled out. But I didn't know it. And so he's there, and he's talking and whatnot, and I'm going, where's the blood on my pants? I said, blood all over my pants. What's this? Here's the chest tube lying on the floor. So I thought, oh, great. But he says, oh, I feel pretty good. I feel a lot better now. Let's try for the other one. But what's the first thing you do? What do you think the first thing you do is? Take a gloved hand and cover the hole. What's the best thing to do? Cover it with a Vaseline gauze. So what's the first thing you do? Cover it with your gloved hand. What's the best thing to do? Vaseline gauze. Because if they say you accidentally pulled out the chest tube, what's the best thing to do? Best thing. And you're between cover it with your gloved hand versus Vaseline gauze. If you pick cover it with your gloved hand, what are you saying? I'm going to cover it with my gloved hand, and that's all I'm going to do. So you're going to follow him around all day long with the gloved hand. No, you're going to put a Vaseline gauze. That actually solves the problem. Do you see the difference? But if they ask first, you're going to put gloved hand, then Vaseline gauze. But best is Vaseline gauze. Forget about the gloved hand. Are you seeing this difference? It's real important, real critical that you see this. Bubbling. They love to ask about bubbling chest tubes. You've seen these questions around? Yeah. Okay, ask yourself 2 questions. Where is it bubbling and when is it bubbling? If you do not ask yourself those 2 questions, you're going to get it wrong. You can get this question right if you ask where and when, because it is going to depend on where and when. Because sometimes bubbling is good and sometimes it's bad. It depends on where and when. So let's talk about it. If I say bubbling, 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 what do you say? Where? I say water seal. Do you see where I'm at? Then what do you ask me? And I say intermittent. Is everybody where I'm at? So intermittent bubbling in the water seal is good. Document it. It's never bad. It's always good. Document it. Okay, I say bubbling, bubbling. You say what? Where? I say water seal. You say? When? I say continuous. This is bad. There is a leak. You do not want continuous bubbling in the water seal. That means there's a leak in the system. You've got to find it and tape it. Put tape over it till it stops leaking. LPNs, this is perfectly within the scope of your practice to put tape on these things to stop the continuous bubbling. I say bubbling, bubbling, bubbling. You say what?
Where?
I say suction control chamber. You say
When?
And I say intermittent. That's bad. The suction is not high enough in that case. If you're only getting intermittent bubbling in the suction control, your suction is too low. You got to go to the wall. You know what I mean by the wall? You know that dial at the wall? And you got to turn it up until what happens? Bubbles how? Continuous. Because if I say bubbling, bubbling, you say where. I say suction control, you say, and I say continuous, that is good. You document that. So, 2 scenarios are good and 2 scenarios are bad. Did you notice that? And what did you notice about the 2 chambers? They're opposite. What's good in one is bad in the other. Now, I do not memorize all 4 of those. I don't. I memorize 1. And then I deduce all the other 3. The one that makes the most intuitive sense to me is this. Think about this. If something is sealed, which chamber am I talking about? If something is sealed,
Water seal.
should you have a continuous bubble? No. That means it's what? Leaking. So that is bad. So intermittent in the seal is, and the suction control is the opposite of that. Because it just makes sense to me. If this were a 2-liter bottle of pop, and it was on the grocery store shelf, and it was sitting there going bubble, 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 bubbling how? Continuously. Would you buy it? No. What's your conclusion about it? The what? Seal is broken. Is it? Don't you in life? When things bubble continuously, you think, oh, the seal's broken. Well, in a chest tube, if it's bubbling continuously, the water seal is broken, and so that's bad. Do you see how I want you to remember it? Did you ever notice that when you do chest tube questions that it is so frustrating because sometimes you're saying it's bubbling is bad, sometimes you're saying, and they say, no, it's okay, and then the next time you say, oh, it's okay, and then they say, no, it's bad, and then the next time you say, oh, it must be bad, and then they say, no, it's okay, and you're going, just make up your mind, is bubbling good or bad, and what's the answer? It's both. It depends. And that's what you're not picking up. You have made all chest tubes the same, right?
Yeah.
And they're very different. See, my philosophy is make something simple if it's simple, but don't oversimplify if it's actually more involved. So hopefully that will help you with your chest tube questions to know when bubbling's okay and when bubbling's not okay, and when draining's okay and when draining's not okay, and what the purpose of it is. Do any of you like analogies? Learn by analogy. Dog is to meow as bark is to cat. You know that you're not good at analogies when I say meow is to cat as bark is to, and you say tree. You know you're not very good at it, you know. But here's an analogy that might help you. A straight catheter, you got where I'm at? A straight catheter is to a Foley catheter as a thoracentesis is to a chest tube. Did you get the analogy? Because what's a straight cath? In and out. What's a Foley? In, secure, drain in. Keep continuous drain. What's a thoracentesis? In and out to reestablish negative pressure. What's a chest tube? Stick it in, secure it, leave it in. So, do you see the point? So just think of a thoracentesis as an in and out chest tube. And that will help you answer questions there too. So which one has a higher risk of infection? Thoracentesis or chest tube? Because what has a higher risk of infection? A straight cath or a Foley? Right? Same idea. Rules for clamping tubes. Never clamp a tube for longer than 15 seconds without a doctor's order. You're not allowed to clamp chest tubes for longer than 15 seconds without a doctor's order. So if you break the water seal, what is the first thing you do? Break the water seal. First thing. Now, how long do you have to get that thing cut off and underwater? 15 seconds. Or you got to what? Unclamp it. So have those sterile water bottles nearby. It drives me crazy. When I work as a nurse and I get people with chest tubes, I go into the room and guess what's all over the walls and all over the over bed table and everywhere? Clamps. I can find like 6 clamps in every room. What can I not find within 100 yards? Sterile water. Which one can I simulate and don't need? A clamp, because I can kink the tube off with my fingers. What can I not simulate? Sterile water. Wish I could, you know. Number 2, use rubber tip double clamps. Use rubber tip double clamps. In other words, if you're going to clamp something, what should they be covered with? The teeth. Rubber. Why should the teeth of the clamp be covered with rubber? Because otherwise you're going to puncture it. That's stupid. And why double clamps? Why 2? Because we're nurses. Okay? There's no research-based evidence to prove that 2 clamps is better than 1. It's just the way we are. Okay?
Double.
Okay, congenital heart defects.
Rubber tip double.
And then we'll do some real brief ones and be done for the day. Congenital heart defects. Everybody knows what congenital heart defects are? Okay, good. Every congenital heart defect is either trouble or no trouble. What I mean by that is either a congenital heart defect causes a lot of problems or it's no big deal at all. There is no in-between defect. That's kind of bad but kind of good. It's either what? All bad or all good. It's either all bad, all good, nothing in between. They're either what? Trouble or they are no trouble. Now, to memorize congenital heart, I want you to memorize one word, and only one word, and that word is trouble. Now you notice it has 7 letters. You notice that shaded box has 7 blanks. I want you to write the word trouble in there, but capitalize the consonants. Keep the vowels small and lowercase. Capital T, capital R, small o, small u, capital B, capital L, small e. Now, all congenital heart defects are what? Trouble or not. So what's the big word you have to memorize for congenital heart? Trouble. Okay, now if you memorize that, how many have that already memorized? You memorized it in the last 10 seconds. Okay, you can repeat that. You now know 95% of all congenital heart defects. How do I know that? Here's how I know it. If a congenital heart defect is trouble, let's say you guys have trouble defects. Does logic say you need or don't need surgery if they're trouble? When? In order to what? Live. Okay, if you guys have a no trouble defect, do you need surgery? No. Might you have it? Possibly when? Years later if it causes a trouble, but we don't expect it to cause any trouble because it's not trouble, right? Okay. Well, what you guys have a trouble defect. What is your growth and development? Slow,
Yeah.
delayed. Why? Because you have a defect which is?
Trouble.
What is your growth and development? Why normal? Because your defect is no trouble. What's your life expectancy? Normal because it's no trouble. What's you guys' life expectancy? Short because it's trouble. What are your parents experiencing a lot of? Stress, grief, financial, all kinds of caregiver issues. What about your parents? No more problems than the average person on the street. Do you go home on an apnea monitor? No, why? Because it's not trouble. You go home on an apnea monitor.
Yes.
Because you have what?
Trouble.
How long do you stay in the hospital after you're born?
Long time.
Weeks? How long do you stay? 24 hours, 36 hours, and you're gone. Why? Because it's no trouble. Who follows your care? What medical professional follows your care? Which doctor? What kind of a doctor? Pediatrician or a nurse practitioner, pediatric nurse practitioner, right? Who could follow you guys? Who will follow you?
Cardiologist.
Pediatric cardiologist. Do you understand what I'm saying? So if it's trouble, make it trouble, and if it's no trouble, don't make it. See, because the way they'll ask this question is they'll say, you are teaching the parents of a child born with tetralogy of Fallot. What will you teach them? And it will say, this decreases life expectancy. This, do you see what I'm saying? Or it'll say, it's just fine, it's no problem. Well, which one do you pick? Well, it depends on whether it's what? Trouble or not. If it's no trouble, what do you tell the parents? Big deal. If it's trouble, what do you tell the parents? Whoa, not good. Now, boards will not give you pictures of defects and ask you what they are. Why? That's not your job. You don't make the diagnosis. The radiologist does. What do you do? What's your role in congenital heart defect? Teaching the parents the implications. And if that's your job, if it's trouble, teach them things that it's going to be a lot of trouble. And if it's no trouble, pick the answer that says this is no trouble. Do you see where you're going to be able to pick the answer out? How many agree you'll be able to know what to teach the parents as long as you know whether it's what? Trouble or not, correct? Okay, now the other thing about trouble is, do you see, is they always want to know, does the defect shunt blood right to left or left to right? Remember that? Mm-hmm. How many remember left to right, right to left shunt? Okay. Look in the word trouble. Look at the way it is spelled. Is there any help for us in remembering which way trouble defects shunt blood?
Right to left.
Why did you say right to left?
R's first.
Because R comes before L in the word trouble. So a trouble defect is right to left. Why? Why is a trouble defect right to left? Somebody said, because it recirculates deoxygenated blood. No, because that's the way it's spelled. It's too late for me to teach you all this stuff. If something can be simple, let's make it what? Simple. And I am not teaching you the word Tlerber. I am teaching you the word what? Trouble. Then in the word trouble, what comes first? R, then L. So trouble defects are
Right
to left because trouble is spelled that way. So what way are no trouble defects shunting blood? Left to right, because that's not the way trouble is spelled, because it's not trouble. So if a kid has a right to left shunt, what do you tell the parents about surgery? Kid has a right to left shunt, what do you tell the parents? Right to left, that's the way trouble's spelled, so it must be trouble. So I'm telling the parents, oh yeah. Okay? But if a kid has a left to right shunt, what do you tell the parents about the growth and development? Left to right. Left to right, that's not the way trouble is spelled, so it cannot be trouble, so we say normal. Are you getting this? Mm-hmm. Okay, the other thing they want to know is the kid cyanotic or acyanotic? Remember that? Mm-hmm. Cyanotic, acyanotic. What does cyanotic mean? Blue. Do we have anything that can help us with that? B. The word B, the letter B in trouble. See, we're using the consonants. We're not going to use the vowels. Just going to use the consonants here. So B means blue. So what types of shunts are blue? What types of shunts are blue?
Right to left.
Right to left means blue. So left to right means not blue, which is pink, acyanotic. You got me? So why are right to lefts blue? Because trouble's spelled that way. Yes. Don't talk to me about deoxygenated blood, because I don't care. I just want to know, can you do this? Okay, now, what do you know about a congenital heart defect? If you know it is trouble, start listing the things you know about it. If it is trouble, what do you know? Shuts blood, what? Right to left. Cyanotic. Needs. Delayed. Decreased. Life expectancy. Needs. Pediatric. exercise intolerance, needs some meds, needs an apnea monitor, is going to stay longer, parental guilt, financial difficulties, caregiver